now. Dr. Hardin is our speaker today. He is an assistant professor of medicine at MGH and a staff intensivist in the Division of Pulmonary Critical Care. His lab studies the biophysics of ARDS. He is also the author of the Hospital Incident Command's Critical Care Guidelines for COVID-19. We've asked him to talk to us a little bit today about management of the critically ill patient with COVID-19. His slides, if you want to follow along or download a copy for yourselves, are available on our COVID site. With that, I'll pass it over to you, Corey. Thank you so much.
Great. So I'm just going to try to share my screen here. I think you have to transfer to me, right?
Let's see here.
Maybe I can do it now because I think before you, oh yeah. Now we're up. I think I can share. Great. So I can just go here. Can you guys, you able to see all of this? Are you getting the scan?
I'm not yet.
Let's see.
Yep.
I see your slides.
Okay, great.
Yep, I see them now as well.
They're there.
All right. So let me just issue an apology in the beginning. Obviously, pandemic rules here, guys. So this was put together quickly. I probably violated all principles of good PowerPoint usage. So just bear with me. I do, as Dan said, I'm going to talk a little bit about ICU management of COVID-19. I'll start out with just a little bit of the situation where we are now. This is as of 5 p.m. last night. This is out of date now. This says that we've got 78 patients, ICU patients who are COVID positive. That's up to, I think, 81 as of this morning. 74 of the 78 were intubated. That's been true throughout the outbreak, is that most of the patients are, the vast majority of the patients are intubated. This is the breakdown by ICU. I just want to highlight over here on the right of your screen here, Lunder 7 and Lunder 9. If you're wondering why you haven't heard of those ICUs before, that's because those ICUs were invented this week. So we've drastically expanded our ICU capacity as we've needed to. And the chart here is just hospital positives and ICU positives. So pretty steady increase. We expect that to continue at least for the near-term future. Just some quick statistics. These are, you have to be careful in COVID-19 because there are lots of unselected case reports out there. I've tried to lean more heavily on the Chinese data because the advantage of having gone first, the Chinese at least have some statistics that summarize all of their cases and so maybe are less biased, but I've also got some information from Italy and Seattle in here. So 5 to 10% of hospitalized patients with COVID-19 require critical care. I think our experience to date is that the percentage is a little higher than that, but who knows exactly what that means. The risk factors are the ones you've all heard of. Age greater than 60, lymphopenia, elevated CRP, elevated IL-6 are all associated with need for ICU and worse outcome. An interesting thing is that there seems to be like a long prodrome. This is not entirely true in the MGH experience, but the reported experience is that the median time from presentation to ICU admission is around 10 days. That's from China. I think the Seattle number is roughly 7. Critical illness and ARDS can present with rapid decompensation, so rapid increase in FiO2, progressive findings on chest imaging, progressive lymphopenia. This observation has led to our practice of relatively early intubations in these patients. I don't have to tell you guys, you're going around the hospital intubating, patients on 4 to 6 liters of oxygen sometimes because we're worried about this rapid decompensation. So what brings patients to the ICU? Well, first, let me just talk a little bit. This data is about a week old now. We're compiling data on all of our MGH experience. So let me just summarize this. The charts here on the left and the right are P to Fs, both the first and the last. P to F, last being on the time of this data collection. You can see there's a range of P to Fs, and they're not all catastrophic, right? We see a lot of 200s to 250s here. The compliance is not terrible, a lot of 30s to 40s. And the PEEP is not super high. So initial PEEP around 10, initial driving pressure also around 10, low airways resistance, static compliance is, not terrible for, it's not like the 15s or 20s that you see in severe ARDS. So I would summarize this. Oh, let me just say that David Zahir, who's one of our fellows, is compiling all of this data and has done really amazing work on, so we have some solid numbers on what we're seeing. So the moderate compliance deficit, hypoxemia ranges from mild to severe, and the patients seem to be responsive to moderate levels of PEEP. That has led to a lot of discussion both at MGH and in the literature as to whether this is really ARDS. So you'll notice in what I've said so far, I've been sort of talking about ARDS and COVID-19 respiratory failure synonymously, and that's not an uncontested viewpoint. So the headline at the top here is a letter that just appeared in the Blue Journal, the ATS American Journal of Respiratory and Critical Care Medicine. This is from Gatnoni in Italy, saying that this phenomenon of moderate compliance, not terrible P to F, and not a lot of dense posterior consolidation is maybe not the ARDS that we're used to seeing. I think in that context, I would just reflect that, while as ICU practitioners, we have this tendency to conflate the severe late ARDS with all of ARDS, that's never been the case as far as ARDS studies. So on the right there, I have data from LungSafe, which was published in JAMA in 2016. It's a large observational cohort of ARDS, sort of a snapshot in time of ARDS around the world, 14 countries represented. They don't have compliance data in LungSafe, but the P-plat, the average P-plat on sort of moderate levels of PEEP is relatively low. So 8 to 10 of PEEP and a P-plat of 22 to 23. So these patients are also not very stiff on average. And the P to F has a range of severity. In the mild, there's 714 mild patients in LungSafe with a P to F of 246. Moderate, or most patients are moderate, so 1,100 with a P to F of 149. And the severe has always been the rarest of the presentations, only 70, P to F of 75 and only 500 patients in LungSafe. So I would say that severe ARDS, the kind that we're used to associating with ARDS in our minds, has always been the less common presentation. And the significance of that is that these patients with the moderate compliance deficit, not terrible P to F, moderate PEEP, have always been in the ARDS studies. So that means the results of those studies ought to be generalizable to the kind of patients that we're seeing now. And I'll just, you guys have seen this before. I don't think I have to berate this for this audience. This is the Berlin definition of ARDS with the mild, moderate, severe categories based on gas exchange, and the familiar definition of acute onset of bilateral chest X-ray opacities, not consistent with heart failure. So that's what ARDS is. It doesn't say anything about compliance here. It doesn't say anything about dense posterior consolidations on CT scan. And so these are the patients that have always been in the ARDS-NET studies. And I want to point out that these are also the patients that we're seeing. So this is data from the New England Journal series that came out, I think it was last Wednesday, the early ICU experience in Seattle. So at the top there, you see the P to F ratios, again, in that 120 to 150 range. Of the patients seen in the ICU in Seattle, 100% had bilateral infiltrates on chest X-ray. So the COVID-19 patients who presented to the ICU in Seattle had hypoxemia in the ARDS range, mostly in the moderate range, and bilateral infiltrates. So they were meeting the Berlin definition. It's fair to criticize defining ARDS by the Berlin definition because it's always been meant to be non-specific, i.e. inclusive, so that we can get all of these patients into studies. If you look at a pathologic definition of ARDS, which is diffuse alveolar damage, that also seems to be the case with COVID-19. So these are just a few available autopsy and pathology studies from COVID-19 so far, but this one from China, you see these two slides on the left here, loss of pneumocytes, hyaline membranes, totally consistent with diffuse alveolar damage. This is a picture from a sort of unpublished this is from Annals Internal Medicine, another Chinese study, again with hyaline membranes. And then the experience in Seattle has not been published yet, but we do. It was presented at Grand Rounds there, and they were gracious enough to let us see their slides. So 9 out of 12 patients in the Seattle autopsy series had diffuse alveolar damage. I also would like to point out, I think it's interesting, perhaps more sociologically interesting than clinically interesting, that this is not a new argument when we're seeing a new cause of ARDS. So this is an editorial by Gordon Rubenfeld, who's one of the major investigator with ARDS-NET, now PEDAL, the sort of NIH-sponsored ARDS consortium. This is an editorial that appeared in July 16, 2003, during the first SARS outbreak. And I would just point out that 3 years after ARMA. So this is 3 years after ARDS-NET1, the low tidal volume ventilation study. And this, again, this is SARS-CoV-1, but SARS-CoV-1 and SARS-CoV-2 are essentially the same virus, roughly 80% sequence homology. They have the same mechanism, spike protein binds to the ACE2 receptor, same clinical presentation, and the same observations were made. But the advantage of looking at SARS, by which I mean SARS-CoV-1, is that we have a little bit more perspective, so we can see. So this is a Toronto series of 38 patients with critical illness secondary to SARS-CoV-1. The risk factors were totally similar: age greater than 60, coronary artery disease, diabetes, elevated CRP, LDH, that should be CK, not DK. So all the things that you're used to seeing and reading about with SARS-CoV-2. And despite the fact that this study was 3 years after ARMA, there was a temptation not to treat these patients with low tidal volume ventilation. So in this series, 6 patients got tidal volumes greater than 8 cc's a kilogram, only 1 survivor. 23 patients got less than, that should be 8, not 6, I apologize. 23 patients, 15 survivors, so a difference in survivability based on tidal volume. They also used a lot of steroids then. There was no difference of survival with steroids. That's roughly consistent with the ARDS literature. So what I would say is, based on the SARS-CoV experience, non-standard ARDS care can actually result in excess mortality. So COVID-19 respiratory failure meets the Berlin definition of ARDS. These patients should be similar to the patients that are in the ARDS trials. Bilateral infiltrates, not caused by heart failure. They're pathologically similar in that they're exhibiting diffuse alveolar damage. So on that basis, I will assert just flat out, respiratory failure in COVID-19 is ARDS and ought to be treated as ARDS. And that, in some sense, should be reassuring to us, because we have a lot of experience with ARDS. Y'all know how to treat ARDS. You've been doing it for years, and we just have to continue to do the things that we've been doing.
Corey, I'll just mention to you,
Yeah.
so we have a mixed audience. We have a lot of people who do critical care, but we also have a lot of folks who their primary area is the main OR. See fewer patients with ARDS.
Yeah, great. I'm going to go through sort of the standard management of it. So hopefully that'll be enough. And my hope is to get through these so that there'll be plenty of time for questions. But thanks for pointing that out, Dan. So what is ARDS? For some of you, this will be review, but this is sort of ARDS pathology in 2 minutes. So starting over on the left here, ARDS is basically a disease of increased permeability of the alveolar capillary membrane. That picture is from the famous Ware and Maffei review in 2000. So the alveolar capillaries become leaky. You get fluid and proteins that leak into the alveolar air spaces. You get inactivation of surfactant, and that results in alveolar instability. And as it progresses, you get cellular apoptosis, and eventually you get complete loss of the alveolar epithelial lining. What that means mechanically is alveolar instability is increase in opening pressure of some units. So what I've got here is a pressure volume curve of the lung. Here's a nice normal one: inspiration, expiration. You say you increase the pressure and you get increasing volume. In the case of ARDS, you have to add a lot more pressure to get any increase in volume. There's this prolonged low compliance state. Then there's this relatively linear, roughly or improved compliance state, and then a decrease in compliance as you overdistend at the high volumes here. So alveolar instability and increased opening pressure, but the real trick with this disease is it's not homogeneous. So here's a CT scan. This is from Gatnoni in 2016. So we have relatively preserved lung, and then we have consolidated lung. So the opening pressure of these lung units down here is high. The opening pressure of these lung units up here is normal. So if you apply an elevated airway pressure with PEEP or apply pressure at the airway opening, you can open up these collapsed units. And the advantage of that is these may still be perfused, right? So there's no black here, so no ventilation, but they may still be perfused. So you have VQ mismatch. And in the case of complete collapse like this, you actually have shunt. The primary mechanism of hypoxemia in ARDS is shunt. So you can open those back up, decrease shunt, improve arterial oxygenation, but at the cost potentially of overdistending here. So these open lung units, the so-called baby lung up here, are likely to end up on the top part of this pressure volume curve, where these collapsed units are down at the bottom, in the posterior area here, are at the bottom of the pressure volume curve. And so it makes it difficult to choose optimal ventilatory strategy, because one part of the lung wants high pressure and one part of the lung wants normal pressure. So there you go, guys, 20 years of pathophysiology in 2 minutes. So let's talk about management of ARDS. And I'll speak in this section a little bit about specifically of management of COVID-19. The first thing that has to be said about management of ARDS, and this applies to septic shock in general, is that there is no specific therapy, and it's not for lack of trying, right? We have tried a number of different agents based on our understanding of the pathophysiology in clinical trials, and none have proven beneficial. Some have actually led to harm, either increase in non-pulmonary organ failures or increase in mortality. And I'm not going to go through this list, but one thing I do want to point out is if you look at this list on the left here, there are a lot of things that may sound familiar to you in terms of things that have been suggested for COVID-19. So we've got heparin down here. There have been trials of both inhaled heparin and also therapeutic anticoagulation with IV heparin. There's IL-1 receptor antagonism, that's anakinra, that's been suggested for use in COVID-19. Certainly corticosteroids have been tried in ARDS, surfactant, various anti-cytokine therapies like anti-IL-6 that's been proposed for COVID-19. So I think when we're evaluating these new therapies for COVID-19, we have to keep in mind this history, in that a lot of these have been tried before in a disease which has the same pathology and the same clinical presentation, so we have to be a little bit cautious. Let me just, if you'll sort of, I'll pause here, Dan, in case there are questions. I see things coming up in the chat. Sounds like not. I'm just going to spend a second on, I won't do too much mechanism here, but I just want to spend a second talking about some of the main therapies that are both in use and being studied in trials, those being remdesivir, hydroxychloroquine, and statins. So a small divergence into biology here. So SARS-CoV-2 is an enveloped virus. It has this spike protein that binds to a cellular receptor. That's generally thought to be the ACE2 receptor, although there's likely others as well. And then it comes into the cell in a so-called endosome, or surrounded by a membrane. And then it has to escape from that endosome. It turns out that escape from that endosome depends on acidifying the internal contents of the endosome, and drugs like hydroxychloroquine interfere with endosomal acidification. Once it's out, the virus, it's an RNA virus, and so it has an RNA polymerase, which makes copies of the viral genome, and you can inhibit that RNA polymerase. So remdesivir, which is an inhibitor of the RNA-dependent RNA polymerase. So there are other drugs that are being developed, vaccines to the spike protein and things, but these are the two main ones. So I'll talk about remdesivir. We are enrolling in the remdesivir trial. Last I heard, the remdesivir trial at MGH was almost completely enrolled. So roughly half of our patients, it's a randomized trial, have gotten remdesivir. It inhibits the RNA polymerase. This was developed to treat Ebola. There's animal data that shows that it inhibits SARS-1. There's not good human data on this. We're working on developing it. Trials are ongoing, and most of our patients who've received remdesivir have done so in the context of a trial. Hydroxychloroquine, I know this has been all over the news. There were dramatic results reported in a small study. This is the hydroxychloroquine and azithromycin study. There are major, major methodologic flaws with that study. Poor use of PCR, uncontrolled small numbers, dropouts from the treatment arm of patients who did poorly. So really questionable data there. There was an attempt to repeat that in roughly 12 patients. That's the Molina study I put there. Same dosing, 11 patients. The outcome there was viral replication by PCR, no effect of hydroxychloroquine. The reason that I'm not just trying to downplay all this stuff, but one of the things that we're seeing in the ICU is a lot of polypharmacy. So almost 100% of our patients are getting hydroxychloroquine. They're all getting statins. Some of them are getting remdesivir. We're seeing elevations of CK. We're seeing LFT abnormalities. In one case, we've seen rhabdo. A lot of these drugs, like the hydroxychloroquine and azithromycin, are QT prolonging, so we've seen arrhythmias. So I think it makes sense in an outbreak situation to try novel agents, but one has to keep in mind the likelihood of success versus the likelihood of adverse events, and particularly when you talk about multiple agents in a single patient.
Corey, a question that's come up to that, and there are a couple others, maybe a quick one. So the first one here that I see with the hydroxychloroquine therapy, someone's asking, they say, you know, it seems that they haven't heard of many side effects from that. Are there side effects from that? Are there reasons we wouldn't want to use hydroxychloroquine?
Arrhythmia mostly. It's certainly safer than chloroquine, but you do see arrhythmia.
Okay. Next question, it says, if part of the problem is different portions of the lung exhibit different time constants, is there a role for adjusting inspiratory and expiratory time in some of these patients?
It's not so much time constants, it's that the pressure needed, it's surfactant dysfunction and instability, right? So it's actually, it's not a kinetic phenomenon. The actual equilibrium pressure needed to open the affected lung units is higher than the pressure needed to open the unaffected lung unit. So since you can only apply a pressure at the airway opening, another way to think about this is even if you waited forever on exhalation, the PEEP required to keep the affected lung units from collapsing is much, much higher than the PEEP required to open the unaffected lung units. So they will in fact be unaffected lung, the so-called baby lung, will in fact be over-distended at the PEEP, which just opens the affected lung.
And then the last question I'll ask you, Corey, it may be something you'll get to later. The question says, we currently at MGH are recommending against high flow and non-invasive because of the risk of aerosolization. The question was that, let's see here. So there are some patients on higher levels of oxygen therapy than 5 to 6 liters, but not needing escalation to mechanical ventilation. There's some studies done in pre-COVID era that show that leak aerosols involved with high flow and non-invasive might even be less than 6 feet. Given the long mechanical ventilatory needs of these patients and dwindling resources, manpower ventilators, would MGH ever consider high flow or CPAP, but maybe not necessarily BiPAP?
Yeah, so I won't say never, but the recommendation against high flow and CPAP is twofold. The aerosol is a real thing, and there was concern based on the New England Journal study that showed persistence of active viral particles on surfaces after aerosolization. So there is a concern with aerosolization. I agree with you that that's not totally mapped out, right? So it is a concern. How big a concern, I think, is an open question. The second part of the recommendation against high flow and non-invasive really gets to the pathophysiology of ARDS. If overdistension of good lung, which result in propagation of injury, it results from the same sort of transpulmonary pressure that's required to open bad lung, that applies whether that pressure is generated by the mechanical ventilator or by diaphragmatic contraction, which is to say, large negative pleural pressures driven by the patient's desire to open up that lung, their high respiratory drive in the setting of hypoxemic respiratory failure, will be injurious to good lung just as much as mechanical ventilation. And that sometimes is startling to people, but there's good data for that. First of all, the physics is the same. The transpulmonary pressure is the transpulmonary pressure, whether it's airway pressure minus a negative pleural pressure or whether it's positive airway opening pressure. There's also fascinating animal studies. It turns out that if you lesion the respiratory center in dogs and let them breathe really high minute ventilations at really high volumes, they will develop ARDS after a period of time breathing at that rate. So mechanical strain propagates lung injury, and heterogeneous inflation results in worse mechanical strain. There's some of the physiology of this, sort of multiplication of mechanical strain in the setting of heterogeneous inflation was worked out at the Harvard School of Public Health years ago by Jerry Mead. So that's all local knowledge in addition to being in the literature. So high flow nasal cannula, in which the patient is still generating large negative pleural pressures, doesn't stop the propagation of lung injury. And so there is some feeling that early intubation can actually sort of cast the lung and prevent the propagation of injury. Now, granted, you do have to balance that against the sort of risk that's associated with high dose critical care, right? With sedation and, intubation and long periods on mechanical ventilation. So that's definitely true. But there is solid reasons to think that allowing a patient in respiratory distress to continue to breathe on high flow nasal cannula may actually propagate injury, and you might be better off intubating that patient. Certainly, if you exacerbate those negative pleural pressures by adding a positive airway opening pressure, such as in non-invasive positive pressure ventilation, that can even worsen. So the recommendation is both based on arguments for increased benefit to the patient as well as concern for staff safety.
Thanks, Corey. I know there's a lot more material to cover, so I'll focus on the other questions and let you continue for now.
Great. So I'll just say one more thing about statins. So statins are interesting. The interest in statins is twofold. One, there is this association, which we saw in SARS-CoV-1 as well as SARS-CoV-2 in cardioprotection, because cardiac disease seems to be a risk factor. There was a large randomized clinical trial of statins as specific therapy for ARDS. That was HARP-2. That trial was negative. There is a reanalysis of HARP-2 by Carolyn Calfee from UCSF that shows that so-called hyperinflammatory patients, which is a phenotype of ARDS that Carolyn has identified, that's associated with elevated IL-6 among other biomarkers, do have a benefit, a lower mortality with statin treatment. But that is a retrospective analysis of a post hoc subgroup, so it's not super solid. So there is interest in statins. I will say we have developed concern because so many of our patients are on statins. I mean, close to 100% are getting statins, and there's not good prospective evidence for it. And again, we're seeing CKs, we're seeing elevated LFTs, and elevated LFTs are, mind you, elevated LFTs are maybe they're not that big a deal, but things like that can bump patients out of trials for antiviral agents. So you can get kicked out of the remdesivir trial. And our history with septic shock and ARDS, or medical critical illness in general, is that the only therapies that have ever shown any promise are those directed at the underlying pathogen. So we are very concerned when we're starting a drug without great evidence that ends up bumping a patient out of a trial for a direct antiviral agent. So lots of interest in these novel agents. The data for them is weak, and we do have to be careful about when we use them. I mean, I think the CHAMP guidelines, the ID guidelines are trying to strike a balance between when do you try these novel agents in patients who are deteriorating versus not wanting to put a ton of patients on agents that you don't know work and may have adverse side effects. So it's a difficult balance to strike. But I will just point out that so far we've ended up with almost everybody on hydroxychloroquine and statins, and I think that we may have overshot there a little bit. I just want to say a word about anti-infectives. Anti-infectives, as I said, usually improve outcome in ARDS and sepsis. Trials of the antivirals are ongoing. There are a lot of other speculative approaches, anti-cytokine therapies. This is TOSI, the anti-IL-6, anakinra, which is a IL-1 receptor antagonist. These have been tried. So there actually is a trial of anakinra in septic shock patients. That was a negative trial. TOSI, we haven't specifically tried, but I will say the elevations in IL-6 that we're seeing with COVID-19 are not specific. Carolyn Calfee's hyperinflammatory subgroup is defined by elevated IL-6, and the numbers are absolutely on par with what we've seen with COVID-19. So, I think it's important to maintain a healthy degree of skepticism about whether a single cytokine inhibition is going to be helpful. It hasn't been in sepsis or ARDS prior. Anticoagulation, as I said, there's trials. They've already failed in ARDS. There's a lot of interest because anecdotally we're seeing CVVH membranes clot and maybe some elevated PTTs in the COVID-19 patients. But that kind of activation of the clotting cascade and even in situ clot is something that we do see with ARDS. And we have tried anticoagulation before. It hasn't proven to be beneficial, although there's some interest in trying it again in COVID-19. Steroids, we don't have time to go over the long and sordid history of steroid trials in ARDS and septic shock. They're harmful late in ARDS, may be safe in early ARDS, no convincing evidence of benefit, DEXA ARDS notwithstanding. which is a trial of steroids, but there's conflicting data, at least on early. Harm late, conflicting data early. But in the particular case of viral pneumonia, there are trials showing harm in steroids with influenza, with SARS-CoV-1, and with MERS, which is another related coronavirus. So we're kind of suspicious of steroids purely for respiratory failure. And what all of that means is that care for COVID-19 will be largely supportive. It's going to be the standard evidence-based ARDS management that we've been doing for a while. And I will pause there again for questions, and then I'll go into what that standard management is. Anything, Dan?
Sorry.
Sounds like not. All right.
I was just unmuting.
Oh, sorry.
It looks like there are a couple questions.
Great.
But some of them are a little bit more specific. So maybe if we can touch on them sort of just generally, and then we can go into even more detail, maybe
Great.
one if needed. So
Yeah.
Some of the questions, what about, are people with an elevated IL-6 considered for early intubation? So in other words, do we have different pathways depending on biomarkers?
Yep. Not yet. There's a lot of interest in that. But you know, the elevations in IL-6 are on the order of 20 to 200 picograms per mil. That's absolutely in the range of what Carolyn Calfee has seen. And she's been working on this since 2013, and we have not clearly defined a differential clinical pathway based on those biomarkers. And IL-6 and Carolyn's hyperinflammatory phenotype is not the first effort to define biomarkers that could guide clinical management. People are, you know, elevated IL-6 is associated with worse outcome in COVID-19. Carolyn has documented that in ARDS in general, but an association with outcome does not mean that you know exactly what to do with that, right? Like a classic example would be the whole history of relative adrenal insufficiency and sepsis, where relative adrenal insufficiency is clearly associated with worse outcome, but treating it with steroids is not clearly associated with improved outcome. So I don't know what to make of the IL-6 elevations, other than to say that we've been trying for years to define clinical pathways based on biomarkers. We have not successfully done it. I personally believe it unlikely that what we've failed to do in the last 20 years, we're going to be able to do in the next 2 weeks in the context of a major pandemic. I think it's interesting to track these biomarkers. We are tracking all of the biomarkers, the ferritins, the IL-6, the CRPs, the fibrinogen, and we're correlating that with gas exchange and pulmonary mechanics parameters. David Ziher is working on that based on our MGH experience. I don't know what the outcome of that will be. I think it could go either way. There's equipoise on that. So I think it's a great research topic and not something that's ready to guide clinical management.
Thank you, Corey. There are a couple other questions that I'm going to write down and just ask towards the end around interleukin antibodies and convalescent serum. But please, I'll bring those up at the end.
Okay. All right. So what is ARDS management? Again, for some of you, this will be review. It is supportive management, but it's evidence-based and it works. So here's sort of the pyramid of ARDS management. The base of the pyramid is the evidence that has the best, or the interventions that have the best evidence, and then going up it gets a little bit worse. So low tidal volume ventilation, this is the single best established intervention in all of critical care. Now, sometimes when I say that, people say, well, what about antibiotics? I'll just say antibiotics obviously have never been tried in a clinical trial. So if you're talking about trial proven therapies, low tidal volume ventilation is the single best proven therapy in all of critical care. So we definitely should be doing that. Conservative fluid management associated with fewer days on the vent. In the FACT trial, I'll go through what conservative means. And then at the top, I put optimized mechanics. So this is the prone ventilation, the PEEP titration, all the things that we normally do on the vent with ARDS patients. So let me just go through those, and we'll sort of do low tidal volume ventilation and mechanics optimization together. So just to get back to the heterogeneity, which is the sort of crux of the problem. So if you imagine that this circle here is a single alveolus, it may be down here on the flat portion of that curve, it may be up here on the other flat portion of that curve, or it may be in here. And where it is will affect what you want to do. Down here, you might add PEEP to get up to this more compliant region and to get better inflation and less shunt. Whereas up here, you might reduce the PEEP to limit the distending pressure so that you're not over-distended, get off this flat portion of the curve and limit mechanical strain and propagation of lung injury. The trouble is you have to do that with only one place to add the pressure. So you want to recruit this and not over-distend this, just to beat the point to death. So this is the ARMA trial. It's the first ARDS trial. This is low tidal volume ventilation. So proportion of patients on the vertical axis, days after randomization on the horizontal axis. And what you see here is both in terms of survival, this black line is proportion of patients alive. And this dotted one down here is proportion of patients not alive. So this is low tidal volume. This is traditional tidal volume. The lowering tidal volumes saves lives. The number needed to treat here is 10, which is pretty impressive. I just want to relate an anecdote because obviously, you know, we're gaining some anecdotal experience with these patients, and it's tempting to want to base practice decisions on the kind of things that we're seeing. Taylor Thompson at our grand rounds last week, Taylor's the National Medical Director of PEDAL, formerly ARDSNet. When they did this trial, again, the single best evidence-based intervention in all of critical care. When they did this trial, they had a final meeting of all of the investigators before the data was analyzed and released. And they took just a show of hands who thought the intervention worked. Not a single person thought low tidal volumes was going to show a mortality benefit. Experienced clinicians, the world's experts on ARDS, could not see a number needed to treat of 10 in their personal experience. So I think the reason I keep harping on leaning on these evidence-based therapies is that personal experience can be very misleading. It's heavily corrupted by cases with high emotional valence. And so these randomized trials, these sort of quantitative compilations of large experience and with randomization of interventions are really, really key. So number needed to treat of 10. I will say that, you know, ARDSNet is more than just 6 milliliters a kilogram predicted body weight. So that's the low tidal volume group. Predicted body weight is based on height. And so, you know, you start on 6 milliliters per kilogram of predicted body weight. The respiratory therapists all have cards and things so they can calculate predicted body weight based on height. Sometimes you still have unacceptable overdistension, which manifests as high airway pressures or high P-plat. So our goal is to keep the P-plat less than 30. If the P-plat was greater than 30, you can reduce below 6 all the way down to 4. Hypercarbia will result, and that's okay. Permissive hypercarbia is sort of a cornerstone of the approach. You can combat that obviously by increasing the respiratory rate up to the point that you get auto PEEP, but it is also okay if the pH goes down. We accept greater than 7.25 in ARDSNet. Some of us would push that to 7.2, but permissive hypercapnia is okay. I will say, the initial settings when these patients first get intubated that we're pushing as part of our guidelines that I'll show at the end, initial tidal volume of 4 to 6, predicted body weight, initial one-size-fits-all PEEP. We can worry about titrating the PEEP when the patient gets to the ICU of 8 to 10 and reduce the tidal volume in PEEP as needed to get that P-plat below 30. Let me just say that low tidal volume ventilation is not for free. And this is absolutely, those of you who have been in the ICUs with these patients will have seen this. They're in hypoxemic respiratory failure. They have a high respiratory drive, and we're trying to enforce a low minute ventilation. It's gonna result in vent dysynchrony, and just some examples of double triggering here. And the traditional way you deal with that in ARDSNet is with sedation. And this moves, you know, militates a little bit against our desire to minimize sedation in the ICU in general, but the low tidal volumes preventing the mechanical strain is of such great benefit that you do go ahead and sedate these patients and even paralyze them if you need to. So okay to increase sedation. We're about to come out with sort of a formal sedation protocol in consultation with pharmacy and some members of your department and ARDS clinicians in our department. Right now, propofol is our first choice. It's requiring a lot of propofol. We're seeing some elevated triglycerides. You do end up having to use opiates because you're trying to ablate the respiratory drive here. Benzos if you need them. Midaz is our first choice. You can certainly go to ketamine if the benzos aren't working. And paralytics for vent asynchrony. For those of you who've been following the ARDS literature for a while, you'll remember that there was a period of time where we were recommending routine neuromuscular blockade. That's not the case now, so just do that if you need to enforce vent synchrony. And I am aware that we're approaching national shortages of some of these neuromuscular blockade agents. We'll just have to deal with that as it comes. We're already switching over to rocuronium from cisatracurium. I mean, shortages will happen, and we'll just have to deal with them on a case-by-case basis. But we don't want to abandon low tidal volume ventilation in favor of minimizing sedation, because we have trial data on this. It results in excess mortality.
Corey, there are a lot of these patients who, for whatever reason, seem to be taking a lot more sedation than our typical ICU patients. And propofol, benzos, narcotic infusions, the whole thing. Do you have a threshold at which you say, okay, let's just paralyze?
Yeah, I mean, I think when the reason that people have been reluctant to go to paralytics, obviously, is you don't want an unsedated patient on paralytics. I think for vent dysynchrony, you do have to use paralytics here. If you're, and not all vent dysynchrony is the same, but if you're seeing double triggering, that's large tidal volume ventilation, right? And so you should paralyze those patients. And I know there's concern about making sure they're adequately sedated. The BIS monitors aren't super accurate, obviously. But listen, when you're on super high doses of propofol and Dilaudid and benzos, you're more than likely adequately sedated. So once you start getting to those, to where you're adding on third and fourth agents, then I think you should just paralyze those patients with whatever agent that you have available, because it does seem to reduce mortality. Are there other questions, Dan, or shall we go on?
There are a couple. Maybe I'll bring them in. One, what's the concern with rocuronium? Is it a steroidal myopathy thing, or is it related to metabolism, or why do we not typically use rock in the ICU?
I mean, practice patterns, basically. I think it's fine to use rocuronium. We have tried to minimize paralytics in ARDS patients and use them only for vent dysynchrony and not routine, because there definitely is myopathy that occurs. ARDSnet just completed, or now Petal just completed the ROSE trial, which was a multi-center randomized controlled trial of routine paralytics. So sort of start the paralytic in on admit for the first 48 hours, not necessarily triggered by vent dysynchrony, and there was no difference in mortality, and there was an increase in myopathy. And I don't mean to minimize the myopathy, right? If you look 1 and 5 years post-ICU stay with ARDS, the main morbidities are actually not persistent respiratory symptoms, they're weakness and PTSD, right? So patients are profoundly weak. So that's real. So we do try to minimize them, but I don't have a strong preference on agent. I think providers naturally reach for the agent that they're most familiar with in terms of dosing, and I think it's fine to switch to rock. And that's what we're going to have to do, because we don't have cisatracurium anymore.
The one thing I'll add is obviously rocuronium's metabolism can be renally dependent, or is renally dependent. So timing considerations for when you're coming off, as opposed to cis. The other two questions about myopathy, and then I'll let you move on, or about paralytics. One is the myopathy dose dependent, or is it more binary? And then the second question is, if you do end up paralyzing, do you have an endpoint for that? So when you stop the paralysis?
Yeah, so let me take the second one first, because I know how to answer that one. I think what I typically do is, when I see compliance and P to F improving, my sense is the vent dysynchrony is driven by respiratory drive, which is driven by the hypoxemic respiratory failure. So that's my trigger. When that P to F is starting to get above 200, then I think you can try to come off the paralytics, and you can try to come down on the PEEP. So basically, improvement is when you try to come off. And thank you, Dan, for your point about the renal failure and renal metabolism. Whether the myopathy is dose dependent, one suspects it is, but that data I cited is it's sort of outcomes data, so it's retrospective, and so use of neuromuscular blockade was coded as used or didn't use. So I don't know that I could give you a good answer on whether it's dose dependent. It seems to be additive with steroid use, but that's sort of all I can say about that.
Thanks, Corey.
Yeah. All right, so let's talk about the other way to minimize mechanics. So the big issue here is that baby lung and the good lung and bad lung. And so in addition to minimizing pressure with PEEP, you want to minimize the tidal volume so that it's appropriate for the baby lung. This was the motivation for ARMA. If the lung is smaller, then you don't want to put a normal sized tidal volume into that smaller baby lung. That's where the term comes from. But we don't know what size it is, right? It's really difficult to figure out how much lung is collapsed. We're not typically taking these patients to the CT scanner. It can be dependent on the level of PEEP. And so the first way that we scale the tidal volume to the size of the baby lung is just an arbitrary number, 6 cc's per kilogram of ideal body weight or predicted body weight. So scale it to the patient's size or the patient's height. An alternative is to scale it by the compliance, because compliance is lung volume dependent. Compliance is the tidal volume divided by the driving pressure, with driving pressure defined as the plateau pressure minus the PEEP, so the elastic distending pressure of the lung. And that means that the driving pressure, just doing the arithmetic, the driving pressure is the tidal volume scaled by compliance. So there was a proposal by Amato, this was New England Journal from 2015, to minimize the driving pressure, to choose whatever tidal volume and or PEEP minimizes the driving pressure. And Amato et al. Made the assertion that it was actually the low driving pressure which was responsible for the decreased mortality signal. So over here you have different cohorts of patients this is a group of all the patients who are in various ARDS-NET trials. So this is a retrospective analysis. And what you see here is that we have patients who all have matched PEEP, right? So all these patients have the same PEEP and their mortality increases as their driving pressure increases. Here are patients who all have the same driving pressure and they might have different PEEP, but all the same driving pressure and their mortality is the same. And here patients who have, these are pleural pressures. So the point here is that the driving pressure, controlling the driving pressure seems to be what drives mortality, and that's represented over here again, where we see driving pressure in centimeters of water and risk of death, and there seems to be an inflection point somewhere between 12 and 15. So we've said as a parameter in these patients to try to keep the driving pressure less than 15. So when you go on that initial PEEP of 8 to 10, check the driving pressure. If it's high on 6 cc's a kilogram, we'll then drop the tidal volume as well. So our parameters for optimizing the mechanics are driving pressure less than 15 and P-plat less than 30. There are obviously a lot of ways to titrate PEEP. There are multiple methods published. There's a 25-year history in the literature of how to do this. None has ever shown itself to be superior. Most people would argue that you should inflate the lung completely and then do a decremental trial. That's sort of a recruitment maneuver, then a decremental trial. You have to be cautious with that because we actually do have a trial, ART, in which that approach, aggressive recruitment and then decremental PEEP trial, was associated with an increased mortality. Now, there have been some criticisms of that trial that it was the wrong subset of patients or whatever, but certainly you shouldn't be doing repeated recruitment maneuvers in these patients. I think it's probably fine as a rescue maneuver for a really hypoxemic patient, but I don't think routine, and I definitely don't think recruited. We're getting a lot of reports from respiratory that patients in our medical ICUs, for example, are getting repeated recruitment maneuvers, like 2 and 3 in a day. There's no justification for that. In fact, it's fine to just set the PEEP by the ARDS-NET low PEEP table. So this is an FiO2 and a PEEP pairing. And it has to be said, as those of us who are interested in pulmonary physiology find PEEP titration fascinating because it's really based on lung mechanics. But there has never been a real trial that shows a benefit to it. And there have been 3 trials that show no benefit and 1 that shows harm to physiologic PEEP titration. So you could do worse than just use the table. I'll pause there again, Dan, in case there's some questions.
I think there are, but just looking at the time, there's some other things we want to get to.
Okay, great. What about prone? I'll go through this quick in the interest of time. So prone ventilation, this is the PROCEVA trial from New England Journal 2013. Prone ventilation has a substantial mortality benefit in ARDS. And the argument here is, again, you can't recruit up lung without over-distending other lung via the vent, but you can prone. If you're in the supine position, your mediastinum and the weight of the mediastinal contents are on your lung. If you're in the prone position, they're on your sternum. The sternum mostly doesn't mind, so you can recruit up that posterior lung without over-distending good lung. And prone ventilation was associated with a substantial mortality benefit. So we're encouraging early prone in these patients. This was the particular ProSiva protocol, but we don't have to go into that. It does have to be said that on meta-analysis and also on this Jeremy Beitler analysis, the patients who benefit from prone seem to be in the low tidal volume ventilation group. One of the things that kept people from adopting a lot of prone ventilation is that prior to ProSiva, there were trials that didn't show a benefit. So ProSiva was kind of a surprise, and it led to some slow adopting of it. When you look back at the prior trials, they were sort of confounded by the fact that a lot of those patients were on large tidal volume ventilation. When you select just the patients on low tidal volume ventilation, there seems to be a substantial mortality benefit. So we're encouraging early prone here. I'll just go through this quickly. We have a nursing protocol for proning. It was written by the CNSs from Blake 12, Ellison 4, Blake 7, and Ellison 9. It's on Apollo, should be rolled out to all the units. We're saying there are very few contraindications, so obviously an unstable spine, sternal fractures, that kind of thing, but not a lot of absolute contraindications. Consider early. If the P to F is less than 150, after you've done your PEEP, you've intubated the patient, done your initial PEEP titration, then prone that patient. Longer periods are safe and effective. We're saying resupine QAM. And I say QAM, not Q24, because when you supine the patient, we're recommending a 2-hour trial to see what their P to F is in the supine position. And if you do Q24, then you supine at 8 a.m., you do a two-hour trial, then you're proning at 10 a.m., and then you're supining again the next day at 10 a.m. You get this creep through the day. Just do it every morning. If that's 23 hours, if it's 26, it's totally fine, QAM. And longer periods are effective. There are reports from other centers reporting days and days in the prone position. Obviously, you do worry about edema in the eyes and that sort of thing, but prone positioning is fine. We are hearing reports of de-recruitment on return to the supine position, so consider adjusting the PEEP. Oftentimes the PEEP goes down in the prone position, so consider adjusting it back up prior to the supine attempt. This isn't really an ICU topic, so I'll just say a large percentage of our COVID-19 patients are getting proned in the ICU. Many centers are experimenting with prone and non-intubated patients in order to forestall intubation. We've just rolled out a protocol this week, and we're doing this on the floor, particularly in patients who are in that early period, that increase of 2 liters to 4 liters of oxygen. So we have a protocol to do that on the floor. We're hoping to hold off intubation in some of these patients who aren't at the point of really increased work of breathing. Maybe Dan, I'll just power through these last couple slides, and then we can do some general questions. Great.
Sounds great. Sorry.
Yeah, of course. So conservative fluid management. So what does this mean? So first of all, why do we do it? High pulmonary vascular pressures can lead to stress failure. Reduction in wedge pressure is associated with improved survival. Autopsy studies of ARDS show lots of extravascular lung water. And diuresis after shock reversal shortens time on vent. That's the FACT trial. So we think volume overload is harmful in ARDS. And so we want to aggressively diurese these patients. But after shock reversal, there's no need to diurese your patient who just got there and has a CVP of 4. You're just likely to cause renal failure. This is the FACT trial, which is so the plot is similar to what I showed for ARMA. So breathing without assistance, meaning so vent-free days was the endpoint here. So more vent-free days on a conservative strategy. What does a conservative strategy mean? Just skip through this. When shock-free, so post-initial fluid resuscitation, no maintenance fluids, diuretics to normalize CVP until off-vent, as tolerated by hemodynamics and creatinine. Obviously, if the creatinine is going up, if every time you increase the PEEP by 2 centimeters of water, your patient gets hypotensive, then consider that that patient is hypovolemic and doesn't need additional diuresis. If patient, so I just said all that. Let me just, since we're talking about shock, let me just talk real quickly about hemodynamics in these patients. Most shock, to the extent that it happens, is distributive, so management does not differ. Levo-vaso as your initial pressors, assess for fluid responsiveness, and give fluid as needed. One of the things that's kind of striking about COVID-19 is it's really primarily respiratory failure. There is comparatively little multiple organ failure. So on the left there, I have data from Wuhan ICU patients in the Chinese outbreak. So only 35% are getting any vasoconstrictive agents, and some of that might be 2 to 4 to levo on propofol. And a relatively low percentage, only 17%, were getting renal replacement therapy. So compared to our usual ICU experience, it's mostly single organ failure. I will say that Seattle numbers are a little bit different. Everybody knows that the Seattle outbreak started in a SNF, a skilled nursing facility. They had sicker and older patients, and they had a higher percentage of vasopressors, so 71%. You've probably all heard about variable reports of a late myocarditis, 7% in one Chinese series. It's hard to know what to make of that. The diagnostic criteria in that series weren't great. Basically, there's a sentence in the report that says, by review of chart, we were able to determine that these patients had myocarditis. So it's difficult from the outside to know what that means. Of note, in the Seattle ICU series, this was in the New England Journal last week, they did echoes on 9 of their 24 patients. 0 of them had left ventricular dysfunction. So the cardiogenic shock is probably rare. That said, we do have one patient who presented with isolated cardiogenic shock, meaning no respiratory failure, no cardiac history, and COVID positive. So it does happen. So don't assume it's distributive shock. It's mostly distributive shock. If your patient's feet are cold and you think it might be cardiogenic, then usual workup, CVO2, EKG, lactate exam, point of care ultrasound. And consider a formal ultrasound. I will say about a formal TTE, point of care is pretty good. This is myocarditis to the extent that your patient does have cardiogenic shock. That's medically managed. You're not going to the cath lab for this. So whether you need to expose another provider and send in an echo tech into that room to make a diagnosis that doesn't have a clear therapeutic import, you should think about. Okay, this is it. So I'm going to finish here. This is our critical care guideline. This is the summary figure from the HICS approved critical care guideline that lives in Apollo. I'll show the link on the next slide. And it basically says what I said. So that's not an accident because I wrote it, but respiratory failure, here's the flow sheet, lung protective ventilation, conservative fluid strategy, PEEP titration prone, various additional therapies, including NO, it's still hypoxemic. There's some labs on the side there. Hemodynamics, norepi, first choice pressure, consider cardiogenic if worsening. Couple changes to usual care. Please don't do daily chest x-rays. They've never been shown to have benefit in ICU patients and they expose additional providers. High threshold for bronchoscopy, that's an aerosolizing procedure, and diagnostically, at least for bacterial superinfection, it's not superior to tracheal aspirate in most cases. High threshold to travel to CTE. Bundle procedures. Some of you will be aware of the new procedure service, COBRA, that's rolling out so that a single provider will do the central line, the A line, renal replacement therapy access, all of that at one time. And consider consulting ID and clinical trial enrollments for these other therapies. And then the final thing I'll say is this, be patient. Once you get these patients intubated, they may be on the vent for a while. In the H1N1 outbreak, a substantial portion of patients were still intubated at 14 days. The mean time of mechanical ventilation in Seattle was 10 days, at least in their early series. There's no magic bullet here. Intubate, PEEP, prone, and wait. It's okay if you round on these patients and nothing has changed from the day prior. You just have to wait for the lungs to heal. And supportive care works. This was 70, but when I wrote it, it's 80 patients this morning. To date, we've only had 1 death, and that was a goals of care situation. 8 discharges and 1 death. So when you think about the fact that we've got 80 intubated patients compared to our usual ICU experience with patients in acute respiratory failure, we're doing really, really well. So these supportive care things really work. Just hold the line. As long as we have vents and N95s, we will get these patients together. We will have good outcomes. So just be patient, do what we know how to do and what we've been doing for a number of years. These are the links. They're in the PDF for the prone guidelines and the critical care guidelines. I will say this Apollo link is the previous version of the critical care guidelines. Version 2 is rolling out this weekend. That's the one I showed you on the slide. So this will be updated shortly. And then I will stop and take any questions. Dan, I don't know what y'all's time is like. I can stay for a little while and answer questions if people want.
That sounds wonderful. We might take advantage of that. So a couple questions that have come in, and then after these, please feel free to just unmute. And as long as it doesn't get too crazy, we can just have people asking questions one at a time. So you addressed this a little bit, sort of what percent of patients have almost only pulmonary disease. The other question was, and you talked a little bit about cardiogenic. could you talk a little, or cardiac rather, can you talk a little bit about renal management and the other one that came in was about GI. I think it probably would be helpful just to mention tube feeds and bowel regs and stuff like that.
Yeah, so I'll start with GI. Yeah, so if you look at one of the amusing things about the various guidelines that's been released by the Surviving Sepsis Campaign, SCCM, in terms of management of COVID-19, you read those guidelines and it's just a complete restating of usual critical care, right? So do what you normally do with tube feeds, right? And what I normally do with tube feeds is it's good to have patients eat, enteral preferred over parental, obviously. Don't get too hung up on it. There's a paper out in the Blue Journal just this week, again, showing that 100% of estimated caloric needs is not superior to 70%. So definitely think about feeding these patients, feed them enterally. Don't get too hung up on it if there's a reason you can't do it in the first 24 hours, but do it as soon as it's practical. Renal and the bowel regimen is worth noting. These patients are on high levels of sedatives, and they're probably going to be on high levels of opiates. So you need to be aggressive about the bowel regimen because there definitely will be ileus in these patients. You know, they're going to get a lot of opiates to enforce low tidal volume ventilation. Renal replacement therapy, the indications are not different than normal ICU care. There have been reports out of New York that renal replacement, that CVVH machines were limited. There does seem to be this phenomenon of hypercoagulability, so we see a lot of clotting on CVVH machines. Eugene Reeve from Renal is talking about doing more just HD on pressors with these patients. As you guys know, there's never been a superiority demonstrated of CVVH versus HD on pressors. And if it's easier to manage in terms of anticoagulation and stuff, then maybe we'll switch to that. For what it's worth, we are not aware of current shortages of renal replacement therapy in our patients. And partly, I think, in the current outbreak, partly I think that's driven by the fact that, that there's not as much renal replacement therapy as you would think for 80 intubated patients with acute respiratory failure. So that's good. Indications are the normal indications. Do be careful about pre-renal renal failure because acute renal failure can get you kicked out of the remdesivir trial. And so you want to be careful about making sure that you've addressed reversible causes of renal failure just so your patients can get antivirals. I think that's all I'll say about that.
I'll add just some other just general thoughts. If your patient would be a hemodialysis or ECMO candidate, one thing that when they're sort of getting plugged in at the beginning to consider is placing a left-sided IJ to save the right IJ for the hemodialysis catheter or ECMO.
Yeah, it's a great point. And one thing we are doing a lot of in our sicker patients is going ahead and placing sheaths for ECMO on arrival. And the reason for that is that these are patients who we think might be heading to ECMO. The reason for that is with PPE and stuff, the time to get a patient on the circuit from the time you decide to do it is prolonged. And so we're trying to sort of facilitate that, bundling the procedures. And so we've had good success with that. We've got, I think, 5 patients on ECMO circuits now, including maybe up to 6. As of yesterday, it was 5, including the VA with the cardiogenic shock. So we are doing ECMO. If you've got a severely ill patient who you think might go on ECMO, it's worth consulting with the ECMO team about whether we should just go ahead and place those sheaths so that we can get them on the circuit quickly.
Just to drill into that a little bit, in talking with the ECMO folks, it sounds like if you are planning to place a sheath, the consultation with them beforehand is considered required before just placing it. The other question then, it's reading between the lines, the patient that you think might go on ECMO, I'm sort of picturing folks with severe ARDS type picture who you're thinking about proning, and is that who you have in mind?
Yeah, so so the way we're thinking about, so PDAF less than 150 after proned, NO, and PEEP titration and paralytics, then you should be talking to ECMO for those patients. Now, there are a number of contraindications. Obviously, if you have a 98-year-old with stage 4 kidney disease who's on 30 of levo, that's not a great ECMO candidate, right? So, you know, but also the usual thing applies about these rescue therapies is don't rule it out, let them rule it out, right? So the people who make the decision about ultimately about whether a patient goes on the circuit in consultation with the ICU team is the ECMO team. So if you have a patient who's going bad, then definitely consult with them and consult with them early and have a conversation.
One question came in about the role of nitric oxide and epoprostenol.
Yeah, so no EPO. we are doing NO where we've recommended it in our, well, let me just state, because there has been some confusion on this point, there is an NO study that Lorenzo is doing. And so there are a number of patients who are on the NO study who are getting NO at separate points in their course from what I'm about to recommend. That's a clinical trial. I won't say much about that. If you're enrolled in the trial, you'll follow the trial protocol. We are recommending NO after you've proned your patient. If they're still hypoxemic, then start NO. And you normally we would start NO at 20 or 40 parts per million. We're going up to 80 parts per million in these patients. It has to be said, the reason that we're using NO late in our protocol is it has never demonstrated that it reduces mortality. You get a transient increase in oxygenation, which goes away by about 24 hours in all of the studies. There is an association with renal failure in a meta-analysis. I don't know what to make of that because, you know, Lorenzo obviously has a paper that he's on that shows it prevents renal failure in cardiopulmonary bypass patients. So, but it hasn't been shown to increase mortality. So we're using it late as a rescue maneuver. So that's, I'm sorry, there was another part of that question about NO. I've lost track. So yes, use the NO.
About epoprostenol.
Oh yeah. So we're not going to EPO because EPO is a nebulized agent. It requires a filter in the vent circuit that has to be replaced every 4 hours. And that requires opening the vent circuit every 4 hours, which is a risk for aerosol generation in staph. So we're sticking with NO.
I'll put together a couple of questions here. One was, have we had any COVID patients who have been decannulated from ECMO? And then the other one that I'll sort of mush together with that sort of wanders into ethics a little bit. Are we having early discussions with families in the most severe cases? If we get to a point where we are constrained for resources, whether that's NO or ventilators or
Yep.
whatnot, how are we planning to approach that?
Yep. So let me do the ethics one first. Oh, well, the first one, I'll do the ECMO one first. No, nobody's been decannulated. There's our first ECMO case in the MICU. As of yesterday afternoon, when I last saw him, was doing much better and looked to be approaching decannulation, but as of yesterday afternoon, had not been decannulated. Things may have changed this morning, but as far as I know, no decannulations. The ethics thing. So yes, we should intensify all of our efforts to make sure goals of care are outlined. One of the things that we've done is there is now an embedded palliative care attending in the ED who is 24/7 in the ED to facilitate goals of care conversations as people who come in. So we should certainly be making sure we have goals of care conversation. I will point out that even outside of the current outbreak, we as attending physicians have always been empowered to not offer therapies that we don't think are beneficial. You're not required to provide futile care. So if in your estimation, ACLS is futile, you're not required to provide that. So we have intensified our efforts to delineate goals of care. You're not required to provide futile care. Now then on the resource issue. So yes, everybody's concerned about what happens when we get resource constrained. There's been a group with HICS, the incident command structure, who's working on what they call the crisis standards of care, which is a formal triage system that will go into assigning points to patients and figuring out how to allocate scarce resources like ventilators. That document has not been released. It's currently at HICS and will be released shortly. So I won't comment on it because the hospital leadership hasn't signed off about it. But there will be a formal triage system that will be triggered by different levels of resource constraints, similar to like a trauma triage situation that will be coming out. The OCC and palliative care and hospital incident command and critical care have been actively working on that document, and it will be coming shortly. Right now, we are not constrained on ventilators. We're good on ventilators right now. We have enough ventilators and ICU beds. By the time we've finished the full surge plan that Catherine Hibbard has put together, we're going to have something like 240 ICU beds that we didn't have. So we have a lot of ICU beds. We have ventilators to cover them. That does include using OR machines. But right now we're not resource constrained. Plans are being made for situations in which we are resource constrained. So I guess that's kind of all I'll say about that.
Thank you. Let's see, 2 other questions have come in. One is maybe a little bit easier. This one's about with the dysmotility that we'll get from opioids? Is there any contraindication to using methyl naltrexone? Any risk of perforation, that sort of thing?
No contraindication other than the usual ones. Obviously, you probably don't want to use it in the setting of bowel obstruction, but yeah, I think you should consider using it.
Great. Second question that came in, and you could probably you could answer the party line, and then you can also tell us your take.
Okay.
If you have a critically ill patient who arrests, obviously it's going to be very difficult to keep PPE in place, and it's going to also be very difficult to ensure that there's no aerosolization from around the cuff and all that sort of stuff. What's the approach?
So the party line is no different from my approach, which is twofold. One, even if it will delay ACLS, staff should fully don PPE. So staff safety first. So that will delay ACLS as people are trying to rush into the room. There's no question, but we still have to do it. If you think that the risk to staff from aerosolization and breaches in PPE or whatever outweighs or is excessive, then you are not required to provide CPR to that patient. You absolutely have to make an assessment of staff safety. And so the hospital is fully behind that. You have to make an assessment of staff safety and staff safety first. We understand that that will delay ACLS. And I think to get to, Dan invited me to share my personal take, so I will say this. These patients are not as sick as our usual ICU patients. Our usual ICU patients, I think we all know ACLS is of limited utility in sort of all comers in the ICU. And these patients are not as sick. They're primarily single organ failures. Some of them are young, but I do think it's fair to make an assessment about whether the risk to staff is excessive in providing a therapy that has to be said has minimal benefit. And we have always been empowered to do that. We are empowered to do that here. And I would separate that issue a little bit from the resource issue. The crisis standards of care are about resource allocation. This is just about staff safety and sort of feudal care. You are definitely empowered to make an assessment of whether you think the risk of aerosol generation is too excessive to provide CPR.
And I'll add too that the cause of all codes is not the same if it's perhaps code from terminal hypoxia versus code from something that would be readily reversible.
Yep.
Another question, and this probably isn't for you, but it's more questions around the anesthesia machine and inline suction.
Yeah, I might let you take that one. I will just say this. The surge plans preferentially allocate anesthesiologists to units that are going to be using the OR machines. We understand that you guys know how to use those machines and we don't. So we're going to sort of cohort them in units that are staffed by anesthesia.
Okay, so I think I've gotten most of the questions. It's possible that I've missed something. If I have missed yours, please unmute yourself and come on the screen. And in the meantime, I will put up the way to get CME credit for this. Actually, I think we're accredited for up to 2 hours, and so you can put in for more than the one because we've gone more than an hour. But any questions, please feel free to unmute yourself and ask Dr. Hardin. And we're getting a number of comments about just with gratitude. Corey, thank you so much for.
Of course, happy to help. You guys are always free to email or page me. Happy to answer any questions and any questions that I can.
Let's see here. So here's a question: is the remdesivir? So remdesivir is now on trial.
Yep.
And the question I guess someone's asking is it also available separately as a therapeutic?
It's to my knowledge, we've been using it exclusively as part of the trial.
All right, just while people may be coming up with more questions, most of it is just thanks that are coming in. Corey, I don't know if it's been your experience as well. My experience with these patients up on Blake 12 is that there's a pretty good amount of to do when they first come in terms of intubation and getting the lines in and sort of seeing where they settle out. But that after that, the sort of the ongoing care needs, it's really just waiting.
100%. I've been joking with our fellows that we ought to implement every other day rounding. You know, it's like stocks. You just put everything in at the beginning and then you wait and you try not to check them too often. I think there's going to be a lot of days where you're just not doing a lot And I think that's fine. I think you just have to wait. I mean, it's sort of tempting to speculate on the biology. You know, this virus is trophic for the AE2 cells. Those are the ones that make surfactant. So I think you're just waiting for that epithelial layer to come back and the surfactant to reconstitute itself. I think that's why we're seeing the prolonged PEEP dependence. And I think there's just no speeding that up. I think you just have to wait.
So here's a question that comes in, and actually this relates to another question that I've heard, which is really good. So I'll ask the two questions together. So one says, I've heard that extubation can result in setbacks. How are we managing success? How do we aim for successful extubation? The other thing that's related to that, we've had folks who are weaned to maybe 5/5 and 25%, and they seem fine for a number of hours. You're thinking about extubating, and then just a tremendous backslide. So I don't know if those two might be related in your mind or not, but would you mind taking those two?
Yeah, so a couple things about that. You know, obviously some patients are going to get reintubated, but reintubation is not as trivial as it normally is because I don't have to tell you guys this, it presents a significant risk to staff. And so we're recommending a couple small changes to our sort of assessment procedure. One, longer SBTs. So when you get to the point of trying 0/0, first of all, do your SBT on 0/0. We need to know how these patients do on no PEEP, and you can take that out to 2 hours. So 2 hours on 0/0. Don't worry too much about breathing through the endotracheal tube. With usual adult endotracheal tube sizes, the resistance associated with that is fairly well tolerated. So a 2 hour 0/0 trial before you think about extubating. And then as you're approaching extubation, when you're weaning, be really, really conscious of the PEEP. What we think is happening is alveolar instability, surfactant depletion. So the PEEP is really therapeutic. And I think the dependence on PEEP is going to be a really good indication of whether patients are ready, both to liberalize from volume control to pressure support and to go from pressure support to extubation or an SBT at least. So come down on that PEEP slowly and don't necessarily think about liberalizing until you're on relatively low PEEP. So I definitely, you know, I would worry, even if the FiO2 is 30, if you're on 8 of PEEP, I might come down on that PEEP a lot more before I try an SBT so that we don't, you know, come down to 5 or something, so we don't get setbacks. And then be cautious about extubation. You're absolutely right about that. We don't want to reintubate. We don't have high flow available necessarily. And so I think the two modifications I would make are a prolonged SBT, insisting absolutely on a 0/0 SBT, and cautious weaning of the PEEP. And then waiting to liberalize from volume control to pressure support until you've seen a real sustained increase in the P to F, by which I mean safely above 200. So 230, 235 to give yourself that little buffer, then think about going to pressure support and be conscious of weaning the PEEP slowly.
Ori, that actually sounds like a terrific suggestion. One thing I was thinking, and I see someone else, Keith Baker's written this as well, it might be a good idea for us to protocolize extubation, and I wonder if that's something you could discuss with the Hicks team.
Yeah, so that I've just outlined is going to be in the next version of the critical care guidelines explicitly. So that as soon as I get that written, that will go to Hicks hopefully today. And then that'll get out, and the new version will have that explicit protocolized approach to extubation and liberalization of tidal volumes.
All right, a couple other questions that have come in. This one says, do you have an idea about the virological course of disease? Is the virus actively replicating and wrecking lungs by, say, day 7 of intubation, or is that more of an immune response and the virus has run its course?
Oh my God, it's the $64,000 question. The short answer is yes. So there is documented viral replication in some patients until the day of discharge or death. So yes, there is a subset of patients who have active viral replication, and their ongoing illness and deterioration is due to direct effect of the virus. There is also a subset of patients who don't have active viral replication and may be suffering from a maladaptive immune response. So yes and yes, we have no idea who is who. And this is the whole history of ARDS literature, is the upregulation of any particular aspect of the host response. Just because you see something upregulated, it's very hard to know whether that is appropriate or inappropriate. And it probably boils down to it's appropriate in some and inappropriate in others. And we do not know who is who. And that's why these immunomodulatory trials have failed as a measure of how little we understand about the immune response. There are currently active trials enrolling in COVID-19 of immune stimulation, GM-CSF for instance, and immune suppression, anti-IL-6 and anti-IL-1 receptor antagonism, for instance. In fact, if you go to clinicaltrials.gov, there is currently a trial of GM-CSF in COVID-19 and a trial of monoclonal antibody against GM-CSF in COVID-19. So we just don't know who is who. And I think that's one of the reasons why it's been really hard to show a benefit with these immunomodulatory therapies. Some patients have active virus. That there's pathology studies from China which show active viral inclusions late in the course. Some patients probably have a maladaptive immune response. We had one patient who had a ferritin over 10,000 who responded well to steroids. There's no way to tell prospectively who is who, and that's the real bitch of it.
Yeah. So one question that kind of relates to that, I guess, in some part, patients who have been extubated, are they tested to see if they're still COVID positive, and have they been in our experience?
So I don't know specifically patients who have been extubated. I will say that when you've recovered from disease, the CDC protocol for when you're sort of cleared to move out of quarantine and get discharged or go to a SNF is asymptomatic for 72 hours. I don't think we're routinely testing those patients for viral replication, but Erica Shenoy and the folks at BioThreats have sort of a whole protocol for when you can relax precautions and when you can say somebody is truly negative. And it is cognizant of the fact that there is both viral replication late, and there is thought to be a syndrome where patients can be PCR negative in the nasopharynx, but still have a viral pneumonia. So my short answer to that is it's complicated, and I would defer to BioThreats on that.
Sounds good. A couple other questions have come up. One is, have there been any thoughts of an extubation team if we are concerned about the needs for reintubation? I suspect that if there is a need for reintubation, it's not going to be right away. It'll be someone who fails over time. But Corey, what are your thoughts?
I don't know that there's thoughts of an extubation team. It's not a bad idea. One of the things that we're doing with our surge planning is sort of creating a more industrial sort of scale approach by piecing out different pieces of the care, whereas normally we might have one team doing all of it. Now we're going to have the COBRA team. We're going to have potentially a proning team that nursing is working on. So, and I know that, obviously RICU has gone to having a COVID-19 specific person. So yeah, it's not a bad idea. I've not heard of any plans to do it.
With regards to the proning, we have one question that came in that said, do we have any particular concerns around proning and exposure? And I think the question actually reads, have critical care team members who prone patients remained safe with the current PPE guidelines?
Yes, 100%. We are recommending that we're typically giving a bolus dose of paralytic at the time of the proning procedure itself, just to prevent tube dislodgement and stuff. Our protocol calls for 5 personnel in attendance during proning, including a respiratory therapist whose job is just to monitor the vent so that you don't have, or the endotracheal tube so that you don't have disconnects from the vent circuit. But that should be done. It's potentially an aerosol generating procedure, and we're doing it, with all of the usual PPE. We haven't had any adverse events of which I'm aware.
So just to clarify, when they're proning, they are using N95s, is that true?
I think anytime you're worried about disconnecting the vent circuit, that's appropriate.
Another question that a couple of times has come in now, what about convalescent plasma?
There's a lot of interest in that. The data for it isn't great. It obviously was used to, some anecdotal success with Ebola. And there's a report recently out, I think it's in JAMA, of 5 patients, or might be Lancet, 5 patients who got convalescent serum in China. So we don't know whether it's effective. It's obviously logistically complicated to set up. We haven't done it here yet. There's some interest. I know there's some folks who are working with some of the blood bank people to look into collecting it. It's not something that we've done here yet.
Okay. Are survivors of COVID-19 immune?
We think so. There are serologic tests that are in use in China that show patients do have IgG, so they do have long-lasting antibodies to it. The virus doesn't appear to have mutated much. Recent isolates are fairly similar to isolates from early in the outbreak, so that suggests there should be long-lasting immunity. It also suggests that a vaccine could be relatively effective. There are isolated reports of patients getting reinfected. It's hard to know what to make of those. They're not any systemic reports. There should be at least some persistent immunity because we know that people have IgG, and we know that the structure of the viral proteins hasn't changed much.
One thing that got mentioned a couple times that I don't think we're looking for an answer, but I'll just mention, there are alternative opioids that we use more in the operating room scenario, but things like remifentanil and sufentanil that may have a role. There was some comment about that early on.
Yeah, pharmacy has discouraged us from using those, and so we're recommending against that.
Okay. This one asks about after extubation. Are we considering anything as a bridge in terms of non-invasive CPAP or BiPAP?
So we're not currently, and that again is a twofold recommendation. One on the aerosol generation issue, and the other that, as you guys know, except in select circumstances, the use of non-invasive post-extubation is not necessarily associated with an improved outcome, and there's a worse outcome in patients who are subsequently reintubated who had a period of non-invasive prior to being reintubated. So the sort of lesson there is if your patient is failing extubation, they should just be reintubated. The exceptions to that, the situations in which we have used a lot of non-invasive are obviously post-extubation non-invasive or high flow are patients with severe baseline lung disease who sort of never look great on an SBT because they've got advanced IPF or advanced COPD, for instance, and morbidly obese who really just need that positive pressure to overcome the positive pleural pressure. That's an unfortunate population because we are recommending against non-invasive there. And what I will say is just make sure those patients are really, really awake before you extubate them and sitting up to the extent that they can. We're recommending against the use of non-invasive post-extubation.
This question, I think I know what your answer will be, but I think it's a good question to get answered. So any utility with APRV or other inverse ventilation strategies?
No. The reason that people find those attractive is that you can lower sedation. The reason that we don't recommend them is that they result in large tidal volumes. So, patients who are breathing spontaneously at P low, for instance, in APRV are generating really large tidal volumes. Patients who are breathing spontaneously at P high in APRV may not be generating large tidal volumes, but they are generating large transpulmonary pressures by virtue of a negative pleural pressure and a large positive airway pressure. So high stress at P high, high strain at P low, it's contrary to low tidal volume ventilation, and we recommend against it. And I will just say that, we're fairly confident that in ARDS, low tidal volume ventilation is more important than minimizing sedation. So I would not use APRV.
Another question that just came in, what do you make of the association between severe disease and hypertension?
It's hard to know. It's hard to know. There are lots of people who are thinking about that. It's also true that if you look at lung safe, for instance, the age distribution and risk factors for death in ARDS in general are about the same as they are for COVID-19. Hypertension is a common comorbidity, particularly when you talk about people who are greater than 60 or 65. So what I make of that is that it's interesting and hypothesis generating. I am as yet unconvinced that it's specific to COVID-19. And I know there's been a lot of attention around the ARBs and the ACE inhibitors and the fact that the virus uses the ACE2 receptor. But I think those are interesting questions in basic biology that to my mind are currently unsettled.
Any thoughts around gender or racial disparities in the COVID cohort that we have?
Yeah, so my thoughts on gender. Sucks to be a man, I guess, in the current outbreak. There does seem to be a male predominance. That was true in the Chinese data and the data we have from the US. That's also true in lung safe. So there does seem to be a predominance. I don't know why. As far as, sorry, the second half of that question.
Racial disparities?
Oh, yeah, I don't know about that. I think it might be an accident of epidemiology. There's been some speculation about the current ethnic breakup of our MGH, or breakdown of our MGH cohort, but I think we have to be careful. These are small numbers. So for instance, initially, we were somewhat lower in age than they were in Seattle, but our outbreak started at Biogen. So we had young, mid-career folks who were coming in. Seattle was older, but their outbreak started at a SNF, so they were older. So I think some of these ethnic disparities, it's too early to say. Numbers are small, heavily influenced by just epidemiologic accident. Which neighborhood did it happen to start in, that kind of thing. So I don't know what to make of that.
Another one that's sort of related to that came in, do you think that the comorbidities, that associations that we're seeing, do you think they drive the age-related outcomes, or do you think it's an age-independent thing?
I think it's probably age. There's been a lot of attempts to correlate the sort of anatomic distribution of the ACE2 receptor with the comorbidities, but it doesn't exactly track. For instance, the highest expression of the ACE2 receptor in the body is in the testes, but we're not seeing a lot of direct viral effect there. People have speculated that that might account for the gender distribution or the sex distribution, but I don't know. There's also a lot of ACE2 expression in tissues that don't seem to be heavily affected. So I just think, you just have to be careful. We don't have solid epidemiology right now. And so some of these associations, I think, probably won't hold up. Maybe some of them will, but I just think it's too early to say.
Terrific. Okay, I think that was the last question that I saw.
Okay.
Corey, I'll finish by reading a text that someone just sent me. Corey is one of those people who I feel like I'm 1,000% smarter after listening to.
That's very kind. I'm glad it was helpful.
Thank you so very, very much.
Thanks, guys. Thanks for having me. And feel free to reach out. Happy to answer any questions. Stay safe, everybody.
Thanks, Corey. You too.
Bye.